So it gives me great pleasure to be able to introduce this next symposium. So this is a joint venture between the American Neuropsychiatric Association and the British Neuropsychiatric Association, these online joint symposiums. So I hope to be able to foster a little bit more in terms of collaborations and doing this moving forward. So this is, we do have someone who is an AMPA Career Development Award winner previously. And I'm going to go ahead and introduce him. We do have a little bit of a change in terms of the order of the speakers. So Colleen Hanlon, who's doing this online, will be second, and then I will be at the very end. So Dr. Shan Siddiqi, it's a real pleasure to have you here, is an assistant professor at Harvard Medical School and the director of the Psychiatric Neuromodulation Research at the new Center for Brain Circuit Therapeutics at Brigham and Women's Hospital. So he completed his general psychiatry residency at Washington University in St. Louis, a neuropsychiatry fellowship at McLean and MGH, and a research fellowship at the Berenson Allen Center for Non-Invasive Brain Stimulation. And his research focuses on personalizing TMS targets using brain circuit mapping and clinical phenomenology. So we will look forward to the connected targeted neuromodulation across symptoms and disorders. Thank you.
Thank you for that introduction. I'm really excited to be here. This is the first time I've given a talk in the UK, so I'll try to speak the same language if possible. Once again, my name is Shan. I'm a neuropsychiatrist in Boston. I'm here to talk about connectome-targeted neuromodulation across symptoms and disorders. And in the US, it's typical to talk about your financiers before you get started, just so you guys are aware. So this is federal grants, foundation grants, some commercial grants, educational funding, et cetera. So I have to start out by giving a brief acknowledgement. I started out when I was younger in high school, I wanted to be a rock star, right? My backup was to be a scientist, but I figured either way I wanted to be the best at what I do. Now I was exposed to American rock, a little bit of Pakistani rock, and I said, you know, I could still do better than this stuff. But then one of my cousins introduced me to Led Zeppelin, and I was like, well, I'm never going to top British rock, so I'm just going to give up on rock music and be a scientist instead. But in any case, I'm going to start out with a quick poll. For those of you guys who are clinicians, or maybe not, which of the following lesion locations do you guys think could increase the risk for depression? This is dogma for a lot of neuropsychiatrists, but anterior cingulate, anybody? Or ventral capsule, ventral striatum, or basolateral amygdala, and dorsolateral prefrontal cortex. Yeah, that's the consensus, right? That's right, dorsolateral prefrontal cortex. The other three spots are actually spots that reduce the risk of depression if they get a lesion there. And they've actually been used as therapeutic targets. For bonus points, left, or right, or both. So the evidence suggests left, but I'm going to talk a little bit more about the strengths and weaknesses of this evidence, starting with a brief history of brain circuit therapeutics for depression. I'm going to talk specifically about depression here because it's the thing that's been studied the most using this approach, but a lot of these lessons apply to other disorders too. And it dates back at least a couple of thousand years to the Greek physician Galen, who first came up with the idea that different parts of the brain do different things. More recently, about 1,000 years ago, Ibn Sina, the Middle Eastern physician, who said that there's a biological basis to brain disorders. But I like to start with 1937, when James Papes described a brain circuit for emotional tree now called the limbic system. And shortly thereafter, Geoffrey Knight here in the UK and Thomas Ballantyne in Boston started disrupting these circuits using surgical techniques such as subcaudate tractotomy and an anterior cingulotomy for depression and OCD and a variety of other things. And they were effective. We use them rarely, but we still use them sometimes. And then a few years later, Robert Robinson in Iowa found that lesions to the left dorsolateral prefrontal cortex seem to cause depression. So I'll say that again. Lesions to the limbic system relieve depression. Lesions to the prefrontal cortex cause depression. And subsequent neuroimaging studies were consistent with this. They found that the depression was associated with hypoactivity in the left DLPFC and hyperactivity in the limbic system, consistent with the lesion studies. So in the mid-90s, a group of neurologists at the National Institutes of Health in the US, sorry, it's not advancing. There we go. Started treating depression using TMS to the left DLPFC, transcranial magnetic stimulation, which in theory might activate that region. So if you break it, you cause depression. You stimulate it, you might relieve depression. And this has become an FDA-approved clinical treatment now, and also it's in the NICE guidelines. And 10 years later, Helen Mayberg started using deep brain stimulation to the subgenual cingulate, part of the limbic system of the PAPE circuit, to treat severe refractory depression also. And of course, some of these studies have failed to replicate, but there's still some promise there with some emerging literature. So one question that I want to tackle briefly, TMS is not as widely used in the UK as it is in the US. So let me give a brief introduction of what this is. It's use electromagnetic induction to induce action potentials focally. So you can you can fire an action potential in a spot with a radius of about 1 centimeter. And the effects are believed to propagate to distributed brain circuits. Here's what the system looks like. And single or paired pulse TMS is often used in physiological studies, so it can stimulate your motor cortex and make your thumb twitch. And that's commonly used to study stroke rehab and things like that. But repetitive TMS is what we use more often, and that's what we usually talk about as psychiatrists. It can induce long-lasting changes by entraining action potentials at a certain rhythm. For depression, repetitive TMS of the DLPFC is now cleared by the FDA and by NICE guidelines here. Takes somewhere between 20 to 50 total treatment sessions, depending on which protocol you're applying, which is delivered somewhere between either a month or as quickly as maybe a week. It takes as little as 3 to 4 minutes per session with some newer protocols. And so that's the basics of TMS. Now, I'm not going to spend this talk talking about how to use TMS in the clinic, but I will talk a little bit about how to think about it. So first of all, I tend to discourage people from thinking of TMS as a treatment per se. It's more of a tool that's used to deliver treatment. I often liken it to psychiatric laparoscopy. You could use it to stimulate any specific circuit for any specific thing. You just have to think about how to use it properly. So often when we use TMS for all sorts of things, studies come out and people think that we're marketing it as a panacea. We're not trying to say it works for everything. We're trying to say that this is a broad spectrum of techniques that can be applied to a lot of different things if used carefully. So different TMS targets and coils are now cleared by the FDA in the US for major depression since 2008, for migraine with aura since 2013, for OCD since 2019, for nicotine use disorder since 2020. And the next one might be alcohol use disorder because a recent multi-center trial just came out to support that. I also discourage people from thinking about TMS as ECT light. They have different mechanisms different clinical applications. Aside from MDD, TMS can be used for OCD, nicotine use disorder. ECT might be used for mania and schizophrenia, different applications for the most part. The mechanisms are different. TMS is generally targeted. ECT is generally diffuse as far as we know. And the tolerability and feasibility is different. TMS, you can walk in, get a treatment, and then go back to work. You don't need anesthesia. There's no cognitive side effects, et cetera. Now, ECT also tends to be more effective. ECT is at least 70% effective. TMS is more like 50 to 70% effective. But thinking about that, I've got another quick poll. What about antidepressants? If a person has failed 3 antidepressants, which in the US you have to fail 4 before you can get TMS, but if a person's failed 3, what's the probability of responding to the 4th one? Anybody think less than 20%? Yeah, we've got consensus on that, right? It's actually probably less than 10% according to this RD trial, but I was being conservative with this. That same patient has a 50 to 70% chance of responding to TMS. So the fact that so I think we're really underutilizing it, because I think if you guys are psychiatrists, you might have some of these patients who have failed 3 treatments, right? Now, one way to think about this is targeting. So we've used it for depression. Everything I've told you about so far is depression. But as we try to think about how to apply TMS to other disorders, we have to think about how to target it, where we're going to stimulate. And right now, we're being very imprecise. The standard procedure is to use scalp landmarks. So in other words, we stimulate your motor cortex to make your thumb twitch. Then we pull out a tape measure. We measure 5 or 6 centimeters anterior to that, and we say that's the spot to stimulate. So I'll say it again. We use a tape measure. The same technology that my tailor uses to hem my pants is what we use to give you electromagnetic brain stimulation. Now, when I first told my wife about this, she didn't believe me. She was like, you psychiatrists have no idea what you're doing, do you? She still doesn't take us seriously. But these landmarks, though, we use for a reason, because it works. So I told you 50 to 70% of patients get better. Of course, 20 to 30% get better with sham, but a lot of patients still get better. And they're based on something. They're based on the locations of lesions that cause depression. If breaking that system causes depression, stimulating it might relieve depression. But the same landmarks have since been used for all sorts of other studies, for PTSD or Gulf War syndrome, as we heard about yesterday, generalized anxiety, addiction, et cetera, with mixed results. And that makes sense. Why are we treating addiction based on the locations of lesions that cause depression? That's not sensible. Now, we have the ability to be very precise about where we target. We can type very specific locations using structural neuronavigation. But all the precision in the world is useless if we don't know the right target. So one thing that we need is a reliable framework to translate lesions to different TMS and DBS targets for different disorders. In our lab, we do that primarily using data science, so we're starting to translate these models into clinical trials now. So I'm going to avoid talking too much about math, but I'm happy to answer questions about that later if anybody's interested. And nobody ever takes me up on that one for some reason. But one question is, how do we find the right spot to stimulate? So traditionally, as neuropsychiatrists, we know brain lesions have been the way that we've studied causes of neuropsychiatric symptoms since the time of Brodmann or even earlier. And here's how that works. You take 3 patients who develop the same symptom, let's call it depression, and you see where their lesion location was, and you say, where do those lesions intersect? Right there, that spot, that must be where depression lives in the brain. Now, of course, it doesn't always work like that. It can get more complicated. So at first, for the first half or more than half of this century, or the last century, there was a rise in brain stimulation and brain lesion studies to try to study what happens in the brain. But then sometime in the 1970s, functional neuroimaging came around and started taking off. And when that happened, lesion studies declined. And this is from a Google Ngram search of the percentage of literature that mentions these terms. And what ended up happening is over the subsequent years, functional neuroimaging became the predominant source of brain mapping research. Brain stimulation made a comeback, and lesions sort of went away. The problem is that this functional neuroimaging techniques, this gives us correlations. It doesn't give us causation. And there's a problem when you try to design treatments based on correlations. As we're talking about treatment targeting here. And so just to illustrate that problem, let me talk about tuberculosis, which is a disease that we know a lot about and that we have very good treatments for. And in fact, the first ever clinical trial was streptomycin for tuberculosis here in the UK. And so but when they did that trial, they already had a causal hypothesis before they did it. They didn't just do the trial to explore causality. There are a few different correlations of TB. For example, TB rates correlate with malaria rates, they correlate with body temperature, with mycobacterial infection, and with travel to endemic countries. But we know that malaria rates aren't causal. This is a spurious correlation, just because both of those things tend to happen in the same places. So antimalarials aren't going to work for TB. Maybe if you give malaria, then they might get better. I don't know if anybody's ever tried that. Body temperature also correlates with tuberculosis, but that's reverse causal. So if you try to reduce somebody's fever, that might make the symptoms better, but it's not actually going to make the disorder better. Even more dangerous is if you looked at white blood cell counts and you saw those were high, and you said, let me try to treat tuberculosis by reducing your white blood cell counts with prednisone. Or actually, prednisone wouldn't do that, but you get what I'm saying. That wouldn't be a very good idea. It would make people worse. Now, on the other hand, mycobacterial infection is the primary cause of tuberculosis. So antimycobacterial drugs are curative. But there are also secondary causes, such as travel to endemic countries. So if you were to reduce travel to endemic countries, that would also improve tuberculosis, or reduce the incidence of tuberculosis. So there's not necessarily one cause. There are often multiple modifiable causes of something. And we think about this differently depending on the context. Yesterday, we heard about how you think about causes from a forensic standpoint. I'm going to focus more on a therapeutic standpoint, where we focus on the modifiable causes rather than the list of them. So what do we mean when I say causal mapping? I told you earlier that we need to do this whole lesion localization thing, but very often, it looks more like this. Different lesions that cause depression might be all over the brain. And some of them intersect, some of them don't. And so you might look at this and say, maybe there's a location that causes depression, maybe there isn't. Well, maybe stroke just causes depression in general and the lesion location doesn't matter. And that's the conclusion that we came to for a long time. But very often, there's a little bit more to it than that. It's not just the location of the lesion, because a lesion might be part of a distributed circuit. It might be connected to something. And if that lesion if those lesions share common connectivity patterns, using either some sort of structural connection like I'm showing on top, or functional connections like I show here, that tells us that they do share something in common. So rather than stimulating a specific location, maybe we can stimulate that whole network that can be defined using structural connectivity or functional connectivity, meaning common fluctuations of the brain, and say, let's stimulate that to find an effective treatment target. But does that actually work? That's a hypothesis. So we started testing that using lesions associated with depression. So some of you guys might have seen this paper in Biological Psychiatry 3 years ago, where we said, okay, let's drive a human depression circuit from focal brain lesions. And we found this spot over here, left DLPFC, consistent with Robert Robinson's work from the 80s, was the spot that was most connected to lesions associated with more depression. And it just so happens to overlap with the 3 TMS targets that were most commonly used for lesional depression or post-stroke depression. So we said, oh, look at that. That might explain why this is working. So in the same issue of the journal, Amit Etkin wrote this editorial where he was generally pretty rosy, but he pointed out an important critique, which they don't usually do that when they write an editorial about your paper, but he was right. He said, it remains to be shown that lesion or stimulation within a particular rest and state network has the same downstream effects on behavior or symptoms. It remains to be shown. He called us out and said that just because it happens to overlap doesn't mean that it's the right spot. You have to show that stimulating the network is better than not stimulating the network. That's what you have to do to define causality. And so how do you define causality in the brain? So when we think about this, again, we've been talking a lot about causality in this conference. We're going to take a different approach to it. How do you actually define causality? Because everything we do in medicine is estimating causality. To actually define causality, you have to give an exposure. You have to then measure the outcome with the exposure. Then you have to go back in time. Then you have to not give the exposure, and then measure the outcome without the exposure, right? Now, this experiment's been done before, but the problem is that it requires 1.21 gigawatts of power, and then you have to either harness lightning or get some Libyan terrorists to steal plutonium, and I need to fly back to the US, and they don't, by the way, I don't know if the Back to the Future reference works as well in the UK as it does in the US. I probably should have chosen H.G. Wells, but in the real world, we have to estimate causality. We can't actually precisely measure it. So that means you can look at something like counterfactual reasoning, which means is doing something better than not doing it, or doing something different? You can look at, and that's useful, but for example, task fMRI does that, but people don't use task fMRI to argue for causality. There are a lot more factors that we have to look at. For example, specificity. This example is intracranial electrical stimulation. If you stimulate one spot in the brain, is that different from stimulating a different spot in the brain, similar to Penfield's experiments in the early 20th century? Experimental manipulations, active versus sham, make a difference. Dose response, does giving a bigger dose make a difference? Is it coherent across different modalities? Does stimulation do the opposite of what a lesion does, for example? Is it reversible? If when you get rid of the stimulation, does it go away? So these are all factors that we can consider when we're trying to find therapeutic targets based on causality. And I see people taking pictures, but we published this last month in Nature Reviews Neuroscience, so you can find it there also. So there's overall, we came up with this continuum saying here are the factors you should consider when looking at the causal relevance of different brain imaging and brain mapping techniques on a scale of 0 to 6.5, because I guess I should have made it 0 to 10, but that would have been too clean. So like I said, if you're interested in reading about this, we published this last month. You're welcome to look at it more. But let me go back to depression. How do we address Amit's comment that I was telling you about earlier? So we found all the different causal sources of information that we could find. For example, brain lesions associated with depression, TMS sites. Now, I told you earlier we use this imprecise tape measure targeting approach, which is imprecise, but the nice thing is that we get a lot of incidental variability in where patients are stimulated. So we can look back at where the patient was actually stimulated and compare that to clinical outcomes, and that's almost a perfect control because the location of stimulation is dependent purely on where the tape measure is on their head, not on anything related to the patient's own features, maybe the size of their head. And we do the same thing with deep brain stimulation. Again, when a DBS stimulator is implanted, the neurosurgeons do a great job of getting it as precise as they can, but there's still a lot of intra-individual variability, like you can see in that top right picture. That's 27 subgenual singular DBS electrodes in 27 different spots. And if they all give us the same answer, if they all converge on a common circuit, then that's something meaningful about causality in the brain. And so we found 14 different data sets with causal sources of information, 713 total patients, including a couple hundred Vietnam veterans with penetrating brain lesions, 200 ischemic strokes all the way from St. Louis to Melbourne, 50 hemorrhagic strokes from Chicago, 150 TMS sites all the way from Boston to Melbourne, 44 deep brain stimulation sites from all the way from Atlanta to Berlin, 32 deep brain stimulation sites for Parkinson's in patients who were then assessed for depression. And as many of you may know, a lot of people develop depression or have improvement in depression after ST and DBS. And 25 DBS sites from the Netherlands in patients who were treated for epilepsy and also were had depression measured. And so what do we do with this? So we first took the brain lesions, mapped them onto a common brain atlas, and used a normative connectome database to see what they're connected to. What that means is we assume that people are more similar than they are different. That's an assumption, but it turns out to be a safe assumption because the differences in the brain lesions greatly outweigh the differences between patients. And so we use just a normative database of what the brain is supposed to be connected to based on 1,000 healthy controls. And we find what each lesion is connected to using restrictive functional connectivity. So this is functional connectivity. And we see if the patient developed depression or not. And we put all that information together and we get a map of connectivity of the brain lesions that cause depression. And we did that for 5 different lesion data sets. And we do the same thing with TMS. We localize a bunch of TMS sites, see what they're supposed to be connected to, see if the patient's depression improved or not, and we get a map of the connectivity of TMS sites that improve depression. And we do that for 4 different TMS data sets. And then finally, we do that with DBS. We get a bunch of DBS sites, see what they're connected to, see if the patient's depression improved or not, and we get a map of the connectivity of DBS sites that improve depression for 5 different DBS data sets. So we ended up with 14 circuit maps across 14 data sets, and this is when I thought, okay, there's no way these can converge, right? I was talking to my primary mentor about this, Mike Fox, and he's a neurologist, I'm a psychiatrist. He was saying, put it all together and see what lines up. And I said, you don't understand. This is psychiatry. Things don't line up, right? Things don't replicate. But he said, try it anyway, and he turned out to be right. Here's what we found. So the connectivity of brain lesions associated with depression significantly matched the connectivity of TMS sites that relieve depression and the connectivity of DBS sites that modify depression. TMS is inverted because it goes the opposite direction in terms of the direction that we're stimulating. Now, these are more similar than expected by chance. Again, happy to talk about the math later if anybody's interested. But the bottom line is that lesions, TMS, and DBS were modifying the same circuit to modify depression. There's some things that are different, but there are a lot of things that are also similar. So what do we do with that information? Well, one thing we can do is try to predict clinical outcomes. I showed you a map. This is the overall map from 14 data sets. It includes the stuff you would expect, like dorsolateral prefrontal cortex, subgenual cingulate, ventromedial prefrontal cortex, things that have been implicated in depression correlatively. But there are also some things missing, like anterior insula, which have also been implicated correlatively. And so now we generated the same map based on 13 data sets and tried to use that to predict clinical outcomes in the 14th data set. And the more connected a patient's stimulation site was to that map, the more likely they were to have clinical improvement with real stimulation, but not with randomly permuted simulations. And this model also outperformed our prior model, which was saying that you should target the subgenual cingulate or connectivity to the subgenual cingulate. This new circuit did significantly better than that. So what does that mean? It means that we think that we have a circuit that's relevant for depression across different diagnoses. We tested it in penetrating TBI, ischemic stroke, hemorrhagic stroke, Parkinson's disease, epilepsy, and primary MDD. But that was in one paper. More recently, what we've been doing is trying to see where else we can take it. So now we replicate it in MS also. So on the left is the connectivity of MS lesions that modify depression. This one's not published yet. And on the middle and right are the same TMS and DBS circuits that I was showing you before. So in other words, MS lesions also share a common pattern of connectivity if they're more likely to cause depression. So let me summarize what I just told you. TMS, DBS, and brain lesions can all modify a common brain circuit. And more importantly, because we already knew this about depression, more importantly, lesions can help us find new TMS or DBS targets, potentially for multiple disorders. And we published this last year in Nature Human Behavior with 26 great co-authors who shared all these data sets with us. Now, we originally submitted this to Nature Medicine, and they came back to us and said appropriately that how can you claim that you developed a transdiagnostic mapping and modulation technique when you only tested it in depression? So we said, yeah, that's a fair comment. So we tried it with the next biggest data set we could find, which was Parkinson's disease. So that's another very common use of therapeutic brain stimulation. So we took a bunch of lesions that are associated with motor symptoms of Parkinsonism from the literature, a bunch of DBS sites that relieve Parkinsonism versus the ones that didn't, and a bunch of TMS sites from clinical trials. We didn't have individual TMS data for Parkinson's. And there are 10 clinical trials that successfully use TMS to that spot for Parkinson's. And again, these significantly lined up. So, so this works not only for depression, but also for motor symptoms of Parkinson's disease. Since then, this approach has also been replicated for cognitive side effects of DBS and Parkinson's and for tics and Tourette's syndrome. So we're starting to think that we can use this to identify treatment targets for other disorders. So the first thing that we wanted to try was PTSD. We used the Vietnam head injury study, which I showed you a little bit about earlier. And there were 193 veterans with penetrating TBI. They also had 52 veterans with non-neurological injuries of similar severity. And this was originally published in Nature Neuroscience in 2008, where they found that 32% of TBI patients met criteria for PTSD compared to 50% of non-neurological injuries. So TBI actually reduced your risk of PTSD. Now that sounds strange after controlling for the severity of the injury. That sounds strange until you look at the fact that it was actually lesions to the amygdala that protected against PTSD, which kind of makes sense. If you don't have an amygdala, you can't get PTSD, right? Problem is you can't target the amygdala with TMS, it's too deep. So we looked at the connectivity of lesions that reduce PTSD risk compared to the connectivity of lesions that did not. And this one's not published yet, but what we found was PTSD risk was reduced for lesions that were connected to the yellow stuff, the medial prefrontal cortex, amygdala, and hippocampus. And we did some split half cross validation to confirm that it's real. Again, happy to talk about the math later. Now, one might look at this and say, okay, well, that's nothing new. You just told me that amygdala lesions protect against PTSD, and amygdala is part of this circuit, so isn't this just the same thing? So we dropped all the amygdala lesions and found the same thing. It was still the same circuit, even if you exclude the amygdala. So it's a distributed network phenomenon, not an amygdala phenomenon. The next question was, is this unique to lesion associated with PTSD, or is it also true for other PTSD? And so we found an independent data set of veterans without brain lesions, and again, PTSD patients were hypo-connected in this circuit on resting state fMRI. So we believe that this tells us something about targeting for PTSD. But we haven't done the trial. We're hoping that somebody else does that part for us, because running the trial is the tedious part. But we also are taking it a step further now, and this one is coming out soon in Nature Medicine, where we've been looking at the connectivity of lesions that protect against addiction. To the left is the connectivity of stroke lesions that led to remission of nicotine use disorder. This was originally published in Science in 2006. Not the connectivity, just the locations, but they had trouble replicating it, so we wanted to look at the connectivity to see if that explains more. So my colleague Juho Jutsa originally looked at this. He submitted it to Science, and they said, no, we're not convinced. So he came to me and said, well, you've got that Vietnam data set. I'm sure a lot of those people had addiction. Can you take a look at that? And here's what that showed. This is the connectivity of penetrating TBI lesions that reduce the risk of future alcoholism. And again, these are more similar than expected by chance. So I'm going to say that again. Stroke lesions that make you less likely to smoke are connected to a common circuit versus penetrating TBI lesions that make you less likely to drink. So what do we do with that information? Well, so here is, based on that, our theoretical optimal TMS target for cravings, or whatever else is in common between nicotine use and alcohol use. Here is the, here it is. And here is the Brainsway H4 TMS coil, which is the one that's now FDA approved for nicotine use disorder based on a multi-center clinical trial. That's what it's stimulating. And this is the H7 coil, which was recently shown in a multi-center clinical trial to be effective for alcohol use disorder. So if we had done this analysis 4 or 5 years ago, they might have been able to, we might have been able to register it a priori. But we now at least have a post hoc explanation for why these treatments might work. So let me summarize what I just told you. Lesions can help us find new TMS or DBS targets for PTSD, addiction, other things also. We're looking at personality, bipolar disorder. But an important question is, how do we then choose the right target for the right patient? Because patients aren't clean. They have a lot of different things going on, right? And this becomes a question of precision medicine in the real world. One afternoon a week, I'm a clinician. The rest of the time, I'm a scientist. And it's hard for the one side of my brain to talk to the other side. But I think this is one way for us to start to transcend that gap. So I've told you about how we might personalize based on comorbid diagnoses. We might choose a different target for PTSD versus MDD versus addiction versus other things. We also looked at symptom clusters, and we've looked at brain connectivity. So I'll tell you a little bit more about those things. So, for example, if you want to personalize by breaking down depression, so looking at individual symptoms of depression. Let's take a few examples: decreased interest, feelings of failure, and insomnia. We can use the same approach, localize a bunch of TMS sites, see what they're connected to, and figure out which connectivity patterns you want to stimulate to improve feelings of interest, which is this, feelings of failure, which is that, and sleep, which is that. Now, each of these circuits end up looking different, right? But any psychiatrist can tell you that these symptoms don't occur in isolation. They tend to be comorbid. They come in clusters. So we clustered them and found this, that there was a top cluster. Stimulation sites connected to the top row improved symptoms like sadness, decreased interest, and suicidal thoughts, whereas TMS sites connected to the bottom row improved symptoms like changes in sleep, decreased interest in sex, and irritability. And so we put this into 2 overall clusters, which we call the dysphoric and anxiosomatic cluster. We intentionally didn't choose terms like melancholic or agitated because we didn't want to create confusion with diagnostic terms. This isn't a diagnostic label. These are just the patterns of treatment response that we observed. And we replicated this in an independent data set also. So low mood, decreased interest, and suicidality mapped to the dysphoric cluster. Trouble sleeping, decreased libido, and worry and irritability mapped to the anxiosomatic cluster. The first data set was collected at our center in Boston. The second one was from the clinical trial that originally led to TMS FDA approval. That was a multi-center trial. Now, these circuits look different from each other, so we were able to combine them into an overall targeting atlas, as we call it, where the magenta spots are the spots you want to stimulate for the anxiosomatic symptoms, and the orange spots are good for the dysphoric symptoms. So some examples of patients who were stimulated at those spots. This patient was stimulated at an anxiosomatic spot and had more improvement in anxiosomatic symptoms. Same thing with this other patient, but it was a different anxiosomatic spot. And this person was stimulated at a dysphoric spot and had more improvement in dysphoric symptoms. And beyond these 3 case examples, we found the same thing across a larger sample too. If we derive the circuit based on, or the target atlas based on one data set, and test it in all the stimulation sites, which are shown as black dots in the other data set, we find that this actually predicts outcomes. The more dysphoric the stimulation site, the more relatively dysphoric the clinical improvement. The more anxiosomatic the stimulation site, the more relatively anxiosomatic the clinical improvement. And that's true with active stimulation, but not with sham stimulation, and also not with a randomly permuted simulation of the active stimulation. So we thought this was real. So the next question was, can we use this to predict clinical trial outcomes? There are a lot of clinical trials of TMS that show heterogeneous results. So we found 14 clinical trials that reported 9 different stimulation sites and showed improvement in in both depression and anxiety. And we found, again, the more dysphoric the stimulation site, the more dysphoric the clinical improvement. And the more anxiosomatic the stimulation site, the more they had improvement in anxiety. We actually successfully predicted which symptom would preferentially improve in 13 out of those 14 trials. So we think that this is useful. So now we're doing our own trial. We're taking people who have both depression and anxiety and randomizing them to get stimulated either at the dysphoric site or the anxiosomatic site to see if we can actually selectively modulate different symptom clusters. Of course, we're doing this trial, launched this trial during COVID, so recruitment is slow, but hopefully we'll have a definitive answer for this question in the next couple of years. So let me summarize what I just said. The target matters. Different targets can modulate different symptoms and behaviors. And the next things we're going to do with this is map more behaviors using different modalities and test these targets prospectively. And if you want to read more about this thing, it was published a couple of years ago in American Journal of Psychiatry. But one added complication, however, is that DLPFC is not just one thing. So the harder we start to look at it, the more we find. The dorsolateral prefrontal cortex is actually quite heterogeneous between individuals, even though it's pretty consistent when you map it multiple times within individuals. So I'll tell you in a second how I made these maps, but this is an individualized brain network map. On the top is my brain. On the bottom is a colleague of mine. We were both senior psychiatry residents at the time, sleep deprived, getting in the scanner at the same time. But you can see our DLPFC looks very different. Not knowing anything about what the colors mean, each color represents a different network. So if we stimulated the same spot, if you stimulated the red spot for me, you'd hit the purple spot for him. The red spot is an attention network, the purple spot is a language network. So we had very different topographies, and that's not just the two of us. This is true in general. This has been shown across much larger samples also. So the question is, can we personalize targets based on a person's DLPFC connectivity? There are a few ways to think about this. One way is to look at it retrospectively at the patients who actually got TMS. So here's something we published last year in Biological Psychiatry, where we identified a personalized target for a bunch of patients and compared it to where they were actually stimulated. The personalized target was identified at the time based on subgenual singular connectivity, because at the time we thought that was the best way to do it. Now we think that we've got a distributed network that's better. We looked at where the personalized target was located, in that blue spot. We compared that to the actual TMS site where the person was stimulated using the black spot. We measured the distance between those two things and used that to see if we can predict clinical outcomes. And indeed, the closer you were to the personalized spot, the better you did. Of the patients that were within within about 1.5 centimeters, 2 centimeters of the personalized spot, all of them had at least 50% improvement. Of course, that's an arbitrary threshold that I put here, but we can see that the people who were close did really well. The people who were farther away didn't do quite so well. The y-axis is clinical improvement. So we think this means that we can personalize treatment. This was published around the same time as another paper came out showing the exact same thing, the exact same effect size, using the exact same method. That was in JAMA Psychiatry by Rob and Cash. So another thing that's coming out soon is figuring out how to do TMS correctly. So I told you earlier that we do maybe 20 treatments, maybe 50 treatments, different doses. We haven't quite figured out the parameter space. And we've been estimating, originally we would do 1 treatment a day, 5 days a week. Why? Because there's 5 weekdays in a week. That's the only reason, right? That's because that's how they did the clinical trials, because they were convenient. But more recently, people have put more thought into this. Nolan Williams' group at Stanford has been using this thing that they call accelerated TMS, where they thought carefully about how they should actually do the dosing protocol. And after doing a few theoretical calculations, they said, you know what? The number of treatments that we're giving in a month, the number of pulses, that's actually the number of pulses that we should be giving in a day. We should be amplifying the total dose by 30-fold per day. And they did that for 5 days. And here's what they found, that each day they had clinically significant improvement in depression. And by day 5, they had roughly 85% remission rates in people who were severely treatment resistant. Now, this led to a lot of skepticism because it was an open label study. They've since replicated this in a randomized clinical trial also. The point that Nolan, the last author in this paper, makes is that, yeah, fine, this was open label, but when's the last time you saw remission rates like this, even in an open label study? And it makes sense that giving a higher dose would be better. The only reason we don't do it is because we're worried about safety, not efficacy. So the patients, they've done this for about 100 patients now, they all get better. And this was sustained for over a month in the original study. They've now got 6-month data to show that it works pretty well. So now we've got we've got the dosing right. The question is, can we get the targeting right? There are a few different ways to do it. So I told you about individualized connectivity in major depression. We can do this for other things too. We can do this for more complex disorders. The way we do this is using something we call an individualized brain network mapping. So you can estimate connectivity between any 2 points in the brain using resonant fMRI. So in theory, you can do it between hundreds or millions of different points in the brain. And when you put that into a clustering model, you find that certain brain regions reliably cluster together, even at the individual level. No matter how much caffeine you've had, how much food you've had, it sort of falls into the same cluster. And again, happy to talk about the math later if anybody's interested. And the networks line up with what you might expect. You got a visual network, a sensory motor network, a default mode network for internally oriented reflection, attention networks that separate out according to what the task fMRI shows also. So so it seems to work. And we can use this to start to individualize brain network landmarks. So for example, on top is a map of the dorsal attention network in light blue, which is involved in externally oriented attention switching, and the default mode network in red, which is involved, or maroon, which is involved in internally oriented reflection and rumination, and the subgenual cingulate, which is a group mean spot that's been implicated in depression. So we can see that there are a lot of similarities, but there are also some differences. Particularly, I'll draw your attention to the DLPFC, where we usually stimulate with TMS. At the group level, there's nothing there in the dorsal attention network. At the individual level, in this particular patient, it was a guy with TBI-associated depression and PTSD. There was a big dorsal attention network spot. And everybody has it. It's just in a slightly different spot. Same thing if I draw your attention to the subgenual cingulate. Some people, it's distinct from the default mode network. For some people, it's overlapping tightly. The disorder in which this has been most involved is traumatic brain injury. So we wanted to get a little bit more information about that. And I just gave away the answer to this next question, which is, which of the following is least likely to respond to conventional antidepressant pharmacotherapy and psychotherapy? Post-stroke depression, anybody? TBI-associated depression, I already gave away the answer. Yeah, of these four, TBI-associated depression is the only one that's been shown, that's had multiple negative clinical trials of SSRIs, whereas the other three have all had multiple positive clinical trials of SSRIs. So, and as we know clinically, these patients look different, they act different, the symptoms are a little bit different, they don't respond as well to treatment. And so we wanted to learn a little bit more about this to try to find a circuit-based target for TMS. And here's how we started doing that. We mapped these networks at the individual level in these patients and wanted to see if connectivity between these networks tells us a little bit about the disease in general. You can't use this sort of thing at the individual level, but it can tell you about the disease if you look at it at the group level. Individualized mapping, but at a large scale. And here's what we found. In patients who were not depressed, connectivity in this circuit was the same regardless of whether they had TBI or not. But in patients who were depressed, it went in opposite directions. TBI-associated depression versus non-TBI-associated depression were affected the same circuit in opposite ways. Now, this might not be a surprise to a clinician who treats these patients. We know that they have similar symptoms, but they're somehow different. We had some physiological evidence now suggesting that TBI depression is not just TBI plus depression. It's a different perturbation to the same circuit. And we then found the same thing in a replication data set with 180 patients. So this one's under review right now. The question is, what do we do with this information? So we can potentially use it to predict therapeutic response. So we've got an independent clinical trial of TMS for TBI-associated cognitive symptoms from a colleague at Stanford. And they stimulated everybody at the exact same spot, at the red spot. And we found the more that spot was connected to that dorsal attention network, the more likely the patient was to have improvement in depression, even though half the patients weren't even depressed in the first place. And that was true for active stimulation, but not for sham, once again. So based on this, I say based on, actually we did this as a post hoc justification, but partly related to this, we actually did a pilot clinical trial showing with just 14 patients, you doing individualized mapping to identify a personalized treatment target. This particular patient was a retired NFL player with repetitive TBI. We picked a very specific target in the dorsal attention network and compared that to sham. Now, we compared the fancy TMS to sham, not fancy TMS to standard TMS, because right now we just wanted to show that the intervention works because nothing else works for these people. And in short, here's what we found. With active stimulation, people got better. With sham, they didn't. So we're now trying to replicate this in a multi-center military trial, which is going to have about 400 patients, and it'll test all sorts of different TMS protocols. That one's underway now, so hopefully 2 or 3 years from now, we'll have, again, a definitive answer to this question. So let me summarize what I just told you. TBI-associated depression is a distinct physiological entity, not just TBI plus depression. And abnormal circuitry in this syndrome, which I like to call TBI affective syndrome. I don't like the term TBI-associated depression because it implies that you should treat it the same way as primary major depression. It can be localized and targeted. So let me conclude everything that I've told you. So TMS and DBS can target the same circuit to treat the same symptoms. Lesions can be used to identify TMS and DBS targets. Depression severity maps to a similar circuit in MDD, penetrating TBI, stroke, epilepsy, and Parkinson's disease, and now also multiple sclerosis. These results are derived from causal sources of information. Different symptoms map to different circuits, and other disorders can also map to circuits like PTSD, addiction, TBI, affective syndrome, et cetera, and personalized brain mapping might actually improve our efficacy. So I tell you all this not because you can do this in the clinic right now, but we're on the verge of this becoming very widespread. TMS has gone from 0 clinical indications to 5 or 4 over the course of many of our careers. And it's only going to grow further. The personalized mapping, the accelerated theta burst, is very close to FDA approval now. There are startups with millions of dollars of funding behind them that are pushing to bring this to the clinic. So I think it's useful to get a sense for how we're thinking about this stuff as it develops into a field of its own. And we just published a perspective article yesterday on how we think this is going to develop into a field of its own in biological psychiatry. So feel free to check that out. So quick acknowledgements. Lots of people helped us make this happen, lots of funding bodies. I showed you data from about 1,500 patients. I think 14 of them I saw myself. The rest of them were from collaborators. And of course, I'm happy to take questions, and I'm even happier to take postdoc applications. Here's my email address, and of course, Twitter is my primary source of scientific communication these days, so feel free to find me there. Thank you.
So thank you for an outstanding talk. We'll open up to questions. I think we have probably a few minutes. Do we have the... there we go. Oh, there's a question down here. And there's a couple up there, too.
Thank you so much. So you told us quite a lot about the where of TMS for personalization, but not a lot about the how much of TMS for personalization. So typically most people use the motor cortex to determine how much TMS someone should get, and then various other parameters for how frequently they should get it, like the same protocol that you mentioned. So what about personalizing that?
Yeah, so that's one of the most common questions that I get. We haven't looked at it. Not a lot of people have looked at it convincingly. I think it's a good idea. You could personalize it based on electrophysiological rhythms, based on EMG mapping. There are a variety of different ways you could think about it, but none of those ways has yet been shown to improve clinical outcomes. So I think what I'm really excited about, there's a lot of work that's just started. One of the challenges with using EEG to find the right rhythm is that surface EEG has poor spatial precision relative to TMS. But a lot of people have been doing really cool work using intracranial EEG to be able to measure a response and say, okay, if there is a certain rhythm, maybe you can entrain the TMS pulse to it. Once we get that physiology right, then I think we'll be on the verge of starting to translate it clinically. But I think right now we don't even have the physiology right. There was one multi-center clinical trial where they tried to titrate it to electrophysiology and it didn't work. There's also the inter-session interval, which we have to figure out. They use 1 hour in the SAINT trials because that's been shown to be sort of the optimal spot based on preclinical studies showing that if you entrain a cat's neuron or a mouse's neuron repetitively, it's about an hour later when it starts to taper, and then you do it again, and it's an hour later that it starts to taper. So, but again, that was based on physiological studies. There have been no clinical studies comparing different approaches.
Thank you.
Thank you.
I'll just bring it to the next person. Who's next?
Thank you. On the latter studies you showed, was it navigated TMS, or were you using tape measures for those?
Yeah, in the latter study, that was the last one that I showed. That was navigated to functional networks. We did individualized mapping of their brain networks, and then neuronavigated to that spot.
Sorry about the next question. In the future, should all clinical treatment be navigated, do you think, or should they be using tape measures?
We're hoping to do, we're trying to get funded to do the clinical trial to test that hypothesis. We'll hopefully have that answer definitively in a couple of years. Based on the retrospective clinical data, the answer would be yes, it should be navigated. The retrospective data are pretty convincing that navigation would improve outcomes. And then the Stanford trial used navigation, and it was the most effective outcomes that we've ever seen. So when this gets FDA approved, they will approve people to follow the clinical trial protocol, which will mean everybody will have to do functional neuronavigation. Whether that actually improves outcomes prospectively remains to be tested. But like I said, we're trying to launch that clinical trial in the next few months.
Okay, we'll take one more question.
Thanks very much. That was a mind-blowing talk for a neurologist. God didn't give us a network to keep us depressed. What's the sunny side of the depression network? What's it for when it's not?
Yeah, that's an interesting question, and our methods don't test that, right? God didn't put that network there to make you depressed. It was there for some other purpose, or maybe it's an interaction between a bunch of different networks that are there for another purpose. What I argue as a psychiatrist is I don't care why it's there. What I care about is how do I modify it to make my patients better. Now, it's an interesting question for the cognitive neuroscientists to work out later, and I'm hoping they figure it out for us. And that's something, by the way, I would love to get a cognitive neuroscientist as a postdoc so we can start testing these questions. But the short answer is, if I speculated, I would probably be I would be outside of what we can support with the data.
Okay. Thank you so much, Shan.
Thank you.